A very warm welcome to all of you for agreeing to be a part of this meeting. And I would just be sharing my slides as regards introducing all the speakers. Is the screen visible?
Yes.
Yes. So first all, we have Dr. Basil Kadura, who's an ophthalmologist. I guess he's moved around the world. He has practiced refractive surgery, has done a lot of work on anterior segment, and now is working as a glaucoma specialist in Sweden. And he's been a faculty to international glaucoma meetings, and I really look forward to listening from him. Next, we have Dr. Vanita Pathakray. I would really like to thank Dr. Vanita for being a part of the event today. She has been unwell, a bad throat, and she's taken steam inhalation throughout the day to be able to speak this evening. So hats off to Dr. Vanita. And she is a senior glaucoma consultant at Center for Sight Hyderabad, has done her glaucoma fellowship from Toronto, a very innovative and passionate surgeon, and her main research interests include MIGS and surgical techniques of glaucoma. Dr. Shirave needs no introduction. He's the president of the International Society of Glaucoma Surgery and associate vice president of the WGA. And his interests are wide, and he definitely goes beyond all surgical realms of glaucoma. Dr. Fakhri is a professor of ophthalmology at Farabi Eye Hospital at Tehran. He's done his fellowship in glaucoma, and I know him from my fellowship days at Wills Eye Institute. He is an astounding speaker, and we look forward to listening from him. Next, we have Dr. Gauri Murthy, a senior consultant in glaucoma at Prabha Eye Center in Bangalore, India. She has published extensively in peer-reviewed journals and has been faculty in national and international glaucoma meetings. She has received the Best Paper Award at GSI and works extensively for secondary glaucomas. So with this, I hand over the mic to now. Sorry, I missed Dr. Sturkar, but I will address that once we come to the talk. So with this, we go on to our first talk from Dr. Basil Kadura, who would be talking about glaucomas, the secondary glaucoma post-cataract surgery. We all focus a lot on primary glaucomas, but I guess it's a good idea to spare a second at secondary glaucomas, which now can occur after every surgical procedure in each subspecialty of ophthalmology. So over to you, Dr. Basil.
Thanks again for the invitation. I'm very proud and honored to be among the glaucoma superstars today with this international congress. I was asked to talk about glaucoma secondary cataract surgery. And we know that pressure spike can happen in the first day after the cataract surgery. About 18 to 45% can have this pressure spike after the operation. But the majority just goes away, and the minority just continue with high pressure after 1 day. And many studies have shown that if the patients don't have any visual field or problem with the optic nerve, so the IOP spike will not cause any damage to the visual field. But if the patient has a glaucomatous cupping or compromised retinal vasculature, maybe visual field damage will occur. And patients with systemic risk factor for ischemic optic neuropathy like diabetes, hyper and hypotony, as well as sleep apnea, can have increased risk for visual field loss from IOP spike. So which eyes have the higher risk for IOP spike? All the eyes with high risk, like the PIX, the IFIS, high myopia or hyperopia, many glaucoma medications, Fuchs dystrophy, or if a complication happens in the operation. And the advice here is to use lower bottle height and slow motion phaco, as Osher described in the 90s. When we, as I said, the minority just continue with high pressure after the cataract operation. And here we have to decide and look exactly when we face a patient with high pressure. Is it open angle? Is it closed angle? And then trying to figure out which the best treatment. So if it's an open angle, the first cause is a primary open angle glaucoma, a patient who has already glaucoma, but the pressure continues to be higher. We know that the phaco operation is good to lower the IOP, but sometimes it can cause IOP spike, like in the extra cap era when alteration in the TM induced by suturing of cornea could happen. And now in the phaco era, it still happens, and this is maybe temporarily because of the inflammation, viscoelastic, or the pigment dispersion. In the femto era as well, we know that ducking can sometimes cause IOP spike day one, but there's case series which show that the visual field indices didn't get worse 1 year after the femtosecond operation in many cases. So what we should do, we should move the OVD and early follow up with prophylactic pressure lowering agents. And unfortunately, there is no agreement which one is the best. Maybe from various studies, we know that combining many agents with many mechanisms is the best, especially in the advanced glaucoma. When it comes to blood-induced glaucoma, we have early high femur from iris trauma, maybe under the operation, or late high femur from MVI, UX, or rarely corneal NV. And we have the ghost cell from vitreous hemorrhage. And the management depends on the cause. We know the medical treatment for the high femur, which agents we should avoid and which we should use, and when to intervene with the AC wash in case of high pressure. And in the late high femur, maybe treating the cause in the eye or removing the lens in the UX. And in ghost cell, many studies have shown that the IOP lowering don't work. So we have to wash the AC if the IOP continues to be high. In uveitis, we know that we should rule out always herpes and maybe other causes, and the eye should be quiet for at least 1 month before the operation, starting the patient with anti-inflammatory drops or maybe tablets 1 week before the surgery. If there's same also, it's good to give the patient periocular steroids under the operation, and we shouldn't be afraid of the IOP spike. We should treat both at the same time. Making a little bit larger rexes is good, and acrylic IO is better in this case. When it comes to lens related, if we leave a little bit of cortical, which can swelling up and cause inflammation and IOP spike, so we should be cautious, as well as if a complication happened and the one quadrant or the lens material just go to the vitreous, it can cause inflammation and IOP spikes. And vitreous in the AC can obstruct the TM, as we know. Steroid induced, we know that it can happen early, especially on those patients who has high risk, like myopes, BUAG, or family relatives to them, as well as diabetes. Now we consider just in many patients just giving them NSAIDs for this reason, especially in high-risk patients, and stopping the medication can just do the trick implant. Now, if we look at the closed angle, it's very rare to happen, but we have been in mind that sometimes closed angle mechanism can happen as well. We know from the EAGLE study and many other studies that fake emulsification is maybe the first line for primary angle closure glaucoma, and it should lower the IOP. But sometimes when we have synovial closure and we have more inflammation and shallow AC after the operation, this could lead to more synovial closure and could worsen the case. So we should sometimes consider gentle unilateral lysis to just open the TM. And if in case of severe glaucoma, maybe it's always better to combine with trap. And when it comes to secondary pupillary block, if you use ICOEL, we should do iridectomy. In the aphakic, it's very rarely now, but first we have to dilate to break the attack, and then iridectomy is required usually. The same thing with the pseudophakic with bacterial synecia. and this can also broken with mydriasis and iridotomy. And no one will have malignant glaucoma, but we should always think about it when we have high IOP and shallow EC. In the malignant glaucoma, the EC is universally shallow, but in the primary angle closure, it's deep centrally. And the management, as we know, we should first do ultrasound to rule out other causes, do PI, and then maybe dilate, and maybe then vitrectomy is the answer with iridozenilo-hyaluronic vitrectomy. My only take-home message is don't just blame the OVD or steroids. Think it's glaucoma with all the variations. Thank you so much for your attention.
Thank you, Dr. Basil. I have a question for you. Do you give an oral carbonic anhydrous inhibitor after the cataract surgery, immediately after the cataract surgery, or do you just let them be?
Not on all patients, just in patients with moderate to high to advanced glaucoma. I just do it and take control one day after the surgery. In other patients, I just use alpha agonist because I want to have two mechanisms. Many studies have shown, surely controversially, but we have to do something at least.
Basil, what about sorry, Farooq, may I?
No, please, yes.
Thank you. What about pseudo-exfoliative syndrome? I mean, you're in Sweden. Half of the patients that you are operating are pseudo-exfoliative. Are you
100%?
100%. Are you giving oral carbonic anhydrase inhibitors as well, or not? After phaco?
No. If it's an eventful cataract surgery, I don't give anything. I just we did one study in the department regarding this, and we didn't found any IOP spikes in patients with PECs. So we don't use it. And most of our patients are 80 plus, so one must consider just the side effects and the contraindications. But I use alpha agonists in all my patients.
Okay. Fair enough.
Do you do gonio wash in your patients who have PECs? After the cataract surgery, do you do an angle wash for your patients?
Yes. Dr. Tariq knows this trans cannula, or what does it call? Very nice cannula designed by a Swiss ophthalmologist to wash. It's called gonio wash, and it's very effective. The studies has shown. But no, I don't do it. In eyes with high pressure with PECs, another thing is we may do phacomigs or medications, but in eyes with PECs without any IOP, high IOP, we don't do anything.
I agree.
Can just do the trick.
Cannula was very fashionable at one point, as you said, Basil. I tried it a little bit. I found that the pressure reduction after the gonio wash is just very transitional. It accumulates again. So it's like sweeping something, and then a sandstorm is continuous, and it will bring back all the material. So I'm not a big believer, to be honest.
I heard about that from your glaucoma workup, Dr. Tariq.
Thank you, Bess. Thank you.
Yes, sir.
Yes, so now we move on to our next talk. That's for glaucoma after bittorrental surgeries, and we have Dr. Vanita Pathakray, who would be enlightening us about this topic. Over to you.
Thank you very much, Parul. And please excuse my voice today. But yes, glaucoma after vitreoretinal surgery is a very well-documented entity. I do not have any disclosures related to this talk. And not only is it well-documented, but it is commonly refractory to conventional therapies also. So just to have a look as to the etiology of the glaucoma, where the surgery is concerned, the pars plana vitrectomy is concerned, you can get it because of injection of gas, silicone oil, or if you've done a scleral buckle or a vitrectomy, and the usual suspects, which have just been elaborated by Dr. Basil, which can happen after any intraocular surgery. And mind you, nowadays, quite a bit of vitrectomies are done with phaco. So when do they present? Some can be acute, few can be chronic, and some can give you both acute and chronic. So acute situations are where you can get an expanding gas bubble, a pupillary block because of the gas or oil, or if a belt buckle has been done, then angle closure is known to happen. And a simple, uncomplicated pars plana vitrectomy can also give rise to a chronic glaucoma. And oil can give rise to both chronic, acute and chronic situations. So gas, as we know, both sulfur hexafluoride and C3F8 are used, and C3F8 is probably a greater, can be implicated more because it expands much more. So ideal composition should be kept in mind. The gas displaces the iris lens diaphragm forwards, leading to angle closure plus minus pupillary block. Here in this case, there was some gas which escaped into the AC also, but the AC was flat. And it can happen in more than 50% of cases, and more so when the zonules are lax, like in pseudoexfoliation. It can rarely induce an internecine cataract also, and I have dealt with a few of such situations, and I have found them to cause an angle closure, and so I have taken them into the OT and done a fairly urgent cataract surgery. Such patients are advised not to travel by air or to higher altitudes, because the volume can increase further, and applanation tonometry is mandatory in these conditions because all other techniques underestimate. So how do we manage? Well, you can start with aqueous suppressants if it's a mild increase, but if there is a pupillary block, you need to do an LPI. And if all this does not help in settling the IOP, then you may have to do a needle aspiration of the glands. The biggest culprit of glaucoma, I feel, is the silicon oil, and it is one of the most challenging to manage. It is used as an adjunct in complex detachments, especially those which have proliferative vitreoretinopathy. It is buoyant, so can lead to a retinal endotamponade, and can occur up to 56% at 8 months. The higher viscosity ones escape less into the AC, and so probably cause less glaucoma. But the mechanisms involved are several. In the early stages, pupillary block and inflammation, cynical angle closure can happen, rubeosis iridis can happen, and migration of emulsified oil into the AC. Here, 2 eyes of same gentleman who had vitreoretinal surgery was left aphakic, multiple reasons for his cornea to have decompensated. You can see bullous keratopathy, and you can see the silicon oil droplets in the AC there, floating in the AC. After tube surgery, his cornea did clear. He did recover moderate vision, and the other eye, he did pretty well. He got 20/20 vision. But the management, as we all know, can be quite challenging. So other than aqueous suppressants, because it is known to cause inflammation, steroids and cycloplegics are a must. It is recommended that a prophylactic inferior PI is done, as the oil is buoyant, of course, but it may close in up to 30% cases, and you may need to use YAG. And if the condition of the eye is such, you're unable to control the pressure and the conjunctiva is poor in condition, then you may have to consider transscleral diode. Surgical management, there is controversy here. Removal of oil is recommended, but whereas Jonas et al. Said that 94% actually resolved, normalized in IOP, Flaxel et al. Said that 100% they got persistence of increased IOP. And I have to say, I do prescribe to the second opinion there. There is, of course, risk of detachment after silicon oil removal. And patients, when they have cynical angle closure, they should be undergoing a concurrent glaucoma surgery. And if not concurrent, they have to be warned that they may need a glaucoma surgery in future. So the surgical management, of course, is challenging because of conjunctival immobility, fibrosis, and traps are difficult to survive in these situations. And conventionally, tubes are placed inferiorly, but this is shown that this oil becomes subconjunctival and induces an inflammation. The tube can be placed in the pars plana when there is simultaneous pars plana vitrectomy done, but this can give rise to more posterior segment complications. There are, of course, some modifications of GTT surgery should be considered. I just want you to have a look at this 13-year-old. This was my early days, who was had aphakic glaucoma and also had retinal detachment twice. So silicone oil was left in situ, and his non-valve tube not only retracted, but you can see it blocking the tube as well as it being subconjunctival. So now what I tend to do is I leave the tube superior itself. I do a lot of intraocular fenestration. So the silicone oil goes and attaches itself there, and the tube never actually gets blocked. The next section, glaucoma after belt buckle, angle closure is known to occur in a small number of cases. The mechanism is congestion of venous drainage, which can lead to swelling of the ciliary body, along with its anterior rotation and shift of the iris lens diaphragm forward. If there's severe ciliocoroidal effusion, we also may get an aqueous misdirection. And of course, there's a greater risk in encircling band and pre-existing narrow angles. So this just tends to be self-limiting, can resolve over days to weeks with cycloplegics alone. And you need not consider laser peripheral iridotomy unless you want to rule out an aqueous misdirection also. And surgery may be indicated when permanent synecdoche form, when a belt buckle and vitrectomy are done simultaneously, as I have seen more and more cases being done simultaneously. So when you have a belt buckle, just a brief video showing you that its presence, whether it's anterior or posterior, determines whether or not you will do it, remove the buckle or not. So in this particular case, I wanted to put a non-valve tube, and I could dissect the muscles out, but the buckle was rather anterior, so I removed it, and in its wake, it left a very large ischemic area, as you can see there. So what I did was, when after I placed the tube, I sandwiched it between two grafts, and the conjunctiva obviously falls short in such situations, and very fortunately, I pull the conjunctiva over, as you will see now, and use these coring incisions to just cover up the two grafts, and it did pretty well. In another case where I wanted to do an EMA glaucoma valve in the superotemporal quadrant in this one-eyed child, 13-year-old, it was the sleeve was sitting right in the superotemporal quadrant. So I removed the sleeve, and obviously after consultation with the vitreoretinal surgeon, it's very easy to remove it. You just need to get into the plane, cut through, and just by engaging very lightly with an MVR blade or even a needle, you can just pull it through, as you can see there. So why does glaucoma happen? Due to uncomplicated pars plana vitrectomy, incidence is known to be up to 20%. It happens due to oxidative stress. And this is a hypothesis that the oxidative stress or the trabecular meshwork causes an open angle glaucoma. Generally, we manage it with aqueous suppressants, but some people do try a trabeculectomy if that does not control pressure. And many surgeons, of course, prefer drainage devices. And how can we not talk about aqueous misdirection when we're talking about surgery? It also happens after VR surgery. We're not sure about the incidence, but can occur after belt buckle, as I've just told you. Has also been reported after silicone oil injection. The mechanism is very unclear. And also uncomplicated pars plana vitrectomy. And what's more, not only that, the pars plana vitrectomy that may be done to treat the aqueous misdirection can also lead to a relapse of the aqueous misdirection. So to end, I will just share with you a very brief video of how I managed that. Here in this particular case, this lady, she had trab and tube done elsewhere. And she presented to me with a flat AC, as you saw in the UBM there. And she had a pupillary membrane, pressure of 26 on 3 anti-glaucoma medication. Posterior segment was fine. So what I did was I utilized the pre-existing peripheral iridotomy, a surgical peripheral iridotomy, used an anterior vitrector, first went vertically down, did a zonulectomy. So this here, what I'm doing is, cutting through the pupillary membrane so that I can actually have a good view, and of course, clearing up patient's vision, and used a vitrector to go through that very small MVR incision vertically downwards, cut through the zonules, and then slowly rotate it and do an anterior hyaloidectomy. So an iridozonular hyaloidovitrectomy. Well, iris was already pre-existent, and that patient did very well. She recovered good vision. And to this day, I think she has about 3 years follow-up. There is no further relapse. So the key points I would like to make here is that depending upon the VR procedure performed, patients respond either to medical therapy, but quite often laser and glaucoma surgery is required, and GTTs form a very important part of this surgical management, and your surgical technique may need to be modified depending upon the problem that you face. Thank you very much for a very patient listening.
Thank you, Dr. Pathak. That was really wonderful. I have a question. In cases with the belt buckle induced high pressures, and if you have to put a tube in these patients, do you dissect a piece of the buckle where you want to insert the tube? So you just let the rest of the buckle be, but just cut that segment from where the tube has to pass?
That's a very interesting idea. I have never thought about it. But once you have an encircling band, and if you're just cutting through a segment, that band is really of no use. There is no tamponade left. So in all these years, I will say the only time that I've needed to abandon a tube in a belt buckle is when I found that the belt buckle was placed over the recti muscles. So I couldn't dissect, and there was too much fibrosis, and of course there was a lot of conjunctival shortening. So I just sewed him up and did a transscleral diode.
And when do you take a call to remove the oil or the gas instead of the VR surgeon? So when you decide that it has to be removed by all means.
See, like I said, I prescribe to the opinion that once 3 months have passed and you have a glaucoma in silicone oil, it is unlikely to improve just with silicone oil removal. Okay. And I find that, in quite a few cases, I am actually correct, and that patient probably goes on to get a glaucoma surgery later or concurrent with the silicone oil removal.
Right. So thank you very much. And thanks once again for joining despite not being well. With this now we move on to Dr. Shiravi, who would be talking to us about glaucoma post-keratoplasty. Dr. Shiravi, please.
Hi, can you see my screen?
Yes, I can.
Very good. Very hard to speak after Vanita. Fantastic talk, incredible experience. I really would like to do a third fellowship perhaps in your place. And I totally agree with you. The only way that removal of silicone would prevent glaucoma happening is if you remove it maybe 25 minutes after you inject it. But once it's there, it's there. Once the trabeculum is damaged, it's damaged. But retina surgeons are kind of marathon players. They want to operate and operate and operate. Anyway, keratoplasty and glaucoma is a very complex relationship. And this is kind of a teaser talk because in 8 minutes, it's impossible to cover everything that needs to be covered. But people who have glaucoma can develop corneal decompensation with time for multiple reasons. People who have corneal diseases and end up with having a keratoplasty can also develop glaucoma, unfortunately. And once you do a keratoplasty, the chances of rejection because of high intraocular pressure is high, and the chances of a patient developing glaucoma just because of the keratoplasty is also high. So it's a significant complication, and the high pressure can lead to endothelial cell loss. A terrible situation. I have published a series of papers maybe 15 years ago about the effect of putting foreign bodies, mainly tubes of various diameters and of various types, and the effect of that on endothelium, which is chronic and is outreaching. Glaucoma can result, is one of the reasons that graft can fail. And people who have preoperative glaucoma, pre-keratoplasty glaucoma have 3 times the potential of a graft rejection. Now, if we speak about PKP, which was till very recently the type of keratoplasty that we're doing most, reports are vary from 10 to 50% of incidence of secondary glaucomas after penetrating keratoplasties. The incidence of glaucoma after PKPs increased significantly if the patient had a herpetic corneal disease, if it is a keratoplasty after trauma, and if it is obviously not the first keratoplasty, second or third, would result into an almost 100% chance of glaucoma developing. Now, DMAC and DSAC are kids on the block, and they are very fashionable nowadays. God knows they have really improved what cornea surgery is for when it comes to keratoplasty. But still, after DMAC, incidence is high, with 15% developing secondary glaucoma. And if DMAC is associated with intraoperative phaco and IOL at the same time, or if we are doing DMAC in cases that are pseudophakic, the chances of developing secondary glaucoma is quite high. The theories behind that are many. Nothing is absolutely written in stone, but the observation has been repeated in multiple publications. So what about DSAC? 35% if there's no history of glaucoma, but if there is a prior history of glaucoma, it can go up to 45%, which is incredibly high, which again means that the cornea surgeon has to be very closely in contact with the glaucoma surgeon. Otherwise, the decisions are usually taken independently, and that can result into a very bad scenarios for our patients. Early onset of spikes of intraocular pressure, and I wouldn't call that glaucoma, I would call that an increase in intraocular pressure spikes that can happen just after phacos. That doesn't mean that they develop glaucoma automatically, but many cases are related to viscoelastic, and there's always a good idea if you have a paracentesis somewhere where you can release a little bit of viscoelastic in the first or second post-operative day. It takes you a minute over the behind the slit lamp. Obviously, you have to clean very well the eye. I would put a betadine eye drops, and I would put antibiotics before and after. I would be as sterile as possible, knowing that I'm doing it in the outpatient clinic. We know that suturing technique and the transplant size affects very much the potential for developing glaucoma. I'm not going to go into details with that. This is more of a session for cornea surgeons, but you can basically read a lot about what can be done in terms of suturing and size to avoid a double-fold increase in the potential for glaucoma development. And of course, inflammation. And inflammation in the eye can come in different forms and in different shapes. And inflammation can result in a spike in intraocular pressure, can result into a secondary open-angle glaucoma, where because of the inflammatory cells blocking the trabecular pressure will go up and can result in damage of the optic nerve. But with time, if inflammation persists and becomes chronic, you know, of course, that synechia can happen, and then it is transformed into a secondary angle closure glaucoma. One of the most troublesome issues with PKPs is that prolonged use of steroids after the operation, and corticosteroid-induced glaucoma is a very elusive type of glaucoma that you can have to manage, because in many cases you can't stop steroids, and in many cases, even if you stop steroids, the pressure can be high. And in many cases, if you stop steroids, the pressure remains high for a couple of weeks before it comes down. So there's a lot of instincts related to what to do with corticosteroid-induced glaucoma, and there's a lot of calculation based on how the optic nerve is. So a person with a 0.99 cup disc ratio and the pressure is 40, you're not going to stop the steroid and wait till the pressure comes down. But if it is 0.5 and it is away from the fixation, maybe you can give the patient, you can tolerate a little bit more, you can have a higher tolerance of intraocular pressure with corticosteroid-induced glaucoma, hoping that at one point of time, soon it will go down. Persistent inflammation is obviously an issue related to keratoplasty that can result in, as I said, secondary open or closed angle glaucoma. What about DMEC? Air bubble induced angle closure can happen. Iridotomies are not always bulletproof for air bubble induced angle closure because the iridotomy itself can be closed with the air bubble. So there are multiple techniques of measuring a specific volume by the corneal surgeons to avoid creation of a pupillary block. But often enough, you get called at midnight because a person who has a DMEC is coming back to the emergency in your unit with a pressure of 60. It happens in as high as 12% of cases. And in DSEC, again, pupillary block would happen or can happen. And here is a study, there is a study that cites 13%. What about measuring IOP after keratoplasty? People say, well, the GAT, the Goldman applanation tonometer, underestimates the pressure. For that reason, people advocate dynamic contour tonometry and the ocular response analyzer. I am very much for using those technologies if they are there, but I wouldn't invest specifically to look after a keratoplasty with a dynamic contour tonometry or an aura. I think it's just pure marketing. GAT, though it is underscoring, but here we have to agree that the pressure, the underestimated pressure, is not going to be from 60 to 22. It will be from 26 to 23. That is not really a massive change. So despite that dynamic contour and aura can provide or can give you better estimate, I don't think that GAT is completely out of the picture as related to measuring pressure after a keratoplasty. What about managing intraocular pressure? Again, here is, this is controversial. Of course, if the pressure is high, you have to give topical medications. How effective they are depends on multiple factors, including the mechanism behind the increase in intraocular pressure. Obviously, carbonic anhydrase inhibitor are something used by many, topical carbonic anhydrase inhibitors are something used by a lot of glaucoma surgeons and cornea surgeons. I am of the school that refrains from topical carbonic anhydrase inhibitors in patients with corneal diseases. I know this is controversial. A lot of people don't believe that, but in some ways, I'm a traditionalist, and traditionally we were taught to avoid carbonic anhydrase when it comes to corneal diseases, and I don't know if maybe in the panel discussion we can touch base on that. SLT can work, but it takes time, and if the pressure is very high acutely, it has to be dropped, and SLT will take a few weeks before it gives you its maximum results. Pupillary block in many cases can be brought down with an ND-YAG iridotomy, though as I just said, it is not bulletproof, and the site of the iridotomy does not have to be classically superior. Sometimes we do it in the 3 and 9, and sometimes even inferior, again, depending on why the pressure is high. And when it comes to treatment, surgical treatment, trabs or deep sclerectomies, again, if the angle is closed because of inflammation, I would not go for a deep sclerectomy, but if the angle is open, even in inflamed eye, I would consider deep sclerectomy before trabeculectomy, mainly because there are lots of studies that have shown. I remember a study by Alain Brun from Dijon, who actually was the first to publish on loss of endothelial cells after trabeculectomy versus deep sclerectomy. So deep sclerectomy has less loss of endothelial cells, significantly less loss. And I think this is important in a graft. We really need to keep those few or these valuable endothelial cells. 5-FU or mitomycin, definitely mitomycin C. Avoid 5-FU whenever you have corneal issues associated. Tubes, sure, but there is a price for tubes because tubes in the antechamber will result into a reduction of endothelial cells. So if I put a tube, I will put it behind the iris. I would rather not put a tube, but if I have to, for one reason or another, I would put it behind the iris, never in front of the iris. And I will stop after one tube. I'm not a big fan of multiple tubes, and I find it ridiculous to put 2 or 3 tubes in a person with a transplanted cornea. I mean, what is the survival potential for this graft after we put 2, or create a Mercedes sign with a 3 tubes? This is not to support or promote Mercedes. I'm a BMW guy. And cyclodestruction is definitely an option. Do not refrain from that. I know that some corneal surgeons would scream foul play when you suggest cyclophotocoagulation. I did not see any real evidence that cyclophotocoagulation would increase graft rejection compared to other procedures. Of course, there is a potential for rejection because of inflammation. So if you do cyclophotocoagulation, you have to bombard the eye with anti-inflammatories. I think with that, I maybe have exhausted my 8 minutes. Thank you very much for your attention, and I'm happy to take questions now or during the panel discussion.
Yes, so I have a question. If you decide to do an SLT, when do you think is the right time post a keratoplasty?
I would rather do an SLT when the eye is calm, when the eye is not inflamed, because the potential of a successful SLT happens when you have a quieter eye rather than an inflamed eye. When would I do it? If the pressure is chronically high, not acutely high, I would try to do it. So I probably would not do an SLT for the first month. I would reserve it for at least 4 weeks after the procedure, and I would not expect a decent result out of SLT before 4 weeks have passed. So I would do an SLT, do not stop medications, and wait and see. And to be honest with you, SLT is halfway to a surgical procedure, and in my hands, an SLT to give you satisfactory results is probably not more than 25% of cases would respond in a decent way. So if we do it, and because we have the luxury and the potential and the flexibility to do it, well and good. If it works fine, the potential for complications after SLT are very low. But bear in mind that it is probably a stepping stone for going to the operating theater.
Right. I would invite any questions from the panel. Well, if there are none, then we would wait more questions from the audience by the end. Thank you, Dr. Sharavi, for such a lovely presentation.
One question, Dr. Parul? Is there
Yes,
time
please.
for me?
Yes, please. Absolutely. Absolutely.
Yeah. Many times we see corneal endothelial decompensation following valve implantation. And when these patients undergo keratoplasty, Dr. Sharavi, what would you be doing for the tube? Because we can't leave the tube touching the endothelium. And subsequently, we can't have the graft fail, but we need the tube for the eye pressure control.
So thank you very much. This is a brilliant question. And unfortunately, this is a question that I have to deal with a lot these days. I have been working in Geneva as head of glaucoma for the last, God knows how many years, 16 years or so. So every tube that I have ever done is coming back to bite me. So a lot of those cases, I actually deal with very good corneal surgeons as well. And our technique to manage those cases is, first of all, to move the tube posteriorly. I'm never going to let the cornea surgeons do DMEC or DSEC or whatever they do, or whatever alphabet they use, while leaving the tube in the anterior chamber. I put it in the posterior chamber. I take the chance to flush it as well. And sometimes I'll do a little bit of servicing for the tube in a very gentle needling, a bit of mitomycin maybe around the plate, but I will take it in backwards, and then I will let them operate and do their cornea stuff. That is, of course, for well-functioning tubes. If the tube is totally fibrosed and the patient is in need of a pressure control and keratoplasty, I would dispense with the first tube completely, remove the tube, and then decide between putting a second tube somewhere else or doing cyclophoto before going for the keratoplasty. But I totally agree with you. If patients who have a decompensated corneas because of a tube in the antechamber, we just send them for cornea people and tell them fix it, taking in consideration that the etiology is still in the antechamber, it will be very bad economy. But it is not a straightforward answer for those cases. It's a case by case, depending if the tube is working or not, depending on how good is the conjunctiva, because in some cases, if the conjunctiva allows, maybe you can do something that is subconjunctival, and thinking again of the potential for the use of cyclophotocoagulation.
Well, thank you. Any more questions? Thank you, Dr. Shravi. And now we move to Dr. Pathakray, who would be talking to us about glaucoma following refractive surgery. Dr. Pathakray, please.
Good evening, my great colleagues from around the world. Okay, many thanks to you for inviting me, and it's my great honor to be with you. Actually, I have some, okay. I have no financial interest in this presentation. My today's topic is about glaucoma following refractive surgery. And as you know, the worldwide prevalence of myopia has increased dramatically over the past decade worldwide. And so is the number of people who wish to be spectacle-free and seeking for and looking for keratorefractive surgery. So from now on, definitely we are facing an increasing number of people who diagnosed with glaucoma and have previously done keratorefractive surgeries. So we should deal with this group of patients. And the question is this: does glaucoma incidence change following keratorefractive surgery? If we look at the risk factors for glaucoma development in a special group of patients, we can see some additional risk factors for glaucoma development. Most patients who seek for keratorefractive surgery or young myopes, some of them undergo LASIK and SMILE with suction ring insertion during the surgery, and they are at risk of developing secondary glaucoma like pigmentary glaucoma and steroid-induced IP rise following prescription of a steroid after keratorefractive surgery. Nowadays, we all believe, based on published data, especially recent published data, that myopia is strongly connected with development of glaucoma. It's widely believed that the incidence of glaucoma is 2-3 times more common in myopic patients than in non-myopic patients. So one of these risk factors, which is myopia, is considered to be an additional risk factor for development of glaucoma in patients who undergo keratorefractive surgery. With regard to LASIK and SMILE, some of these patients definitely do LASIK or SMILE, and during LASIK or SMILE, due to suction ring insertion, we have a transient and dramatic IP rise during the surgery. There are some reports on occurrence of optic neuropathy and visual field defect which are attributed to this IP spike during the surgery, during the LASIK or SMILE. But based on published data, especially recent published literature, it's very unlikely that this transient IP rise during the LASIK can cause glaucomatous optic disc damage or RNFL dropout in healthy eyes. Maybe it can cause damage to the glaucomatous patient during the surgery and not for healthy eyes. There are some reports of impairment of blood flow during LASIK and the SMILE. There is a case of Uret-Zavalia syndrome reported that is attributed to pressure rise and subsequent ischemia, iris ischemia during the surgery. There are some reports on non-ischemic optic neuropathy after LASIK and some reports on angle closure for hyperopic LASIK. But the association between IP rise and glaucomatous optic disc damage is not clearly documented. With regard to IOP to steroid response in this group of patients, as you know, 1/3 of patients or people are considered a steroid responder, and about 5% of persons are considered strong responders. And this depends on the type, potency, and frequency of steroid administered and the route of administration, which is considered topical for after keratorefractive surgery. And it's important to consider the susceptibility of the patient to IOP rise following the administration of a steroid. It usually occurs within 1 month following the administration of steroid, and usually goes back to the normal levels in most cases following the discontinuation of the steroid use. What are the susceptibility of patients to steroid IOP rise? It's been shown that glaucoma suspect patient and patient with ocular hypertension, patient with primary open angle glaucoma, and also patient first degree relative of primary open angle glaucoma are increased risk for steroid IOP rise. And also patient with a history of previous steroid IOP response, male sex, a younger age, patient with type 1 diabetes, and patient with myopia, especially high myopia, are considered stronger responders to steroids. And also it's been documented and published that myelin gene that is strongly associated with steroid induced IOP rise is also connected to myopia. So it should be put in mind that myopia is a risk factor for IOP rise following steroid use. In a study published by Dr. Jawadi and colleagues, they were looking for factors associated for post-PRK ocular hypertension. They found that male sex, high CCT, low mean K reading, high myopia, corneal haze, and stronger steroids are strongly associated with ocular hypertension following steroid use in PRK. And in a recently published study by our group, we looked for IOP trend following myopic PRK. We included 348 patients for this study. We did tonometry with Corvis tonometer before and 4 months after the surgery. And we found that more than 12% of our patients experienced a steroid-induced IOP rise more than 5 millimeters of mercury. And all cases of IOP rise occurred during the 4 weeks after the surgery. And risk factor for this IOP rise were based on higher baseline IOPs and less CCTs. So we should be careful about the patients who are candidates for keratorefractive surgery with a baseline higher IOPs. With regards to connection between keratorefractive surgery itself and the incidence of glaucoma following keratorefractive surgery, there's a published study by Dr. Song and colleagues from Korea. They want to look for the association between glaucoma incidence following keratorefractive surgery. They included 604 patients that had history of keratorefractive surgery in the past, and compared them with a control group of more than 3,000 people with myopia more than 3.
My apologies, Dr. Pathakray, we are running short of time, and I'm getting a reminder from the next session to just hasten up the session. So if you could please conclude this.
Okay. The most important, so based on published data, we don't have increased incidence of glaucoma following keratorefractive surgery itself. We should consider steroid response as a risk factor for glaucoma. But the most challenge of glaucoma detection and glaucoma evaluation for progression is a tonometry, which is based on CCT changes and corneal biomechanic changes, and also corneal curvature change. IOP is underestimated in this group of patients. We should look for IOP underestimation in this patient. We may overlook patient with glaucoma because of underestimation of IOP. So it's been shown that Corvis is the most accurate tonometer, and AirPuff is the most inaccurate tonometer in these patients. And we don't have much problem for optic nerve and retinal nerve fiber examination, for imaging of retinal nerve fiber layer and macular imaging, and also visual field, except for some peripheral visual field depression, especially in patients with large pupils. So we have challenge in glaucoma evaluation and detection in patients. We don't have much problem for management of glaucoma in these patients, except for worsening of ocular surface disease and also epitheliopathy that may comes from some topical anti-glaucoma medication, and also development of some kind of cataract due to our intervention. Many thanks to you.
Thank you so very much. And with this, I think we should move on to our next talk. Dr. Gauri Murthy would be talking to us about glaucoma following trauma, and trauma is as global as glaucoma. So over to you, Dr. Murthy.
Yeah, thank you, Dr. Parul. We all know that ocular trauma has a higher lifetime prevalence than reported for glaucoma, AMD, and diabetic retinopathy, and also that blunt trauma accounts for the highest number of blind eyes. So trauma is definitely important. And basically, trauma, we are dividing it as open globe, closed globe, and chemical injuries. Glaucoma is a possibility in all the three. So when you're looking at a glaucoma due to trauma, you have to look at the mechanism of intraocular pressure raise. So in the broad open angle mechanisms, we have angle recession. So you can see here that there is this band beyond the scleral spur. The ciliary body band is very wide. It's wider than the combined width of this anterior trabecular and posterior trabecular meshwork. So angle recession is one of the mechanisms. Trabeculitis or inflammation post-trauma is also a mechanism, and blood products, and sometimes denatured blood, like this long-standing hyphema, ghost cells, can occlude the trabecular meshwork and produce ghost cell glaucoma. Steroids are a common culprit, as in many other situations. And hemosidrosis, this is like a rare situation. Here you can see that there is heterochromia and anisocoria, and the patient gave a history of trauma. So in such patients, you should think about hemosidrosis causing the glaucoma. The closed angle glaucoma mechanisms are also many. You can have a pupillary block due to many causes. It can be due to the lens, it can be due to the vitreous, and it can be due to peripheral anterior synechiae. So closed angle due to peripheral anterior synechiae, when you have chromatic aniridia like this, the stump can block the angle and cause glaucoma, and PAS even otherwise due to inflammation can form. Epithelial and fibrous ingrowth is one of the late causes, and rarely you have posterior pushing mechanism like suprachoroidal hemorrhage, orbital hemorrhage, and even a carotid cavernous fistula following a trauma, which can lead on to glaucoma. So it's important that the management should address the mechanism of glaucoma. So I just go through a few cases. I can't go through the whole of this traumatic glaucoma because the time is short. This was a lady who presented with raised pressure and history of blunt trauma to the eye. And when examined, you can see that there is a sphincter palsy over here. And you can also see glaucom flecken over here. And on slit lamp examination, there was considerable phacodonosis, and it is pupillary block due to the lens moving forward, which is causing the glaucoma in this patient. So intermittent attacks have caused this glaucom flecken to form. So unless and until you address the root cause of this, you relieve the pupillary block by either removing this lens or doing a PI there is a risk of the lens dislocating. You have to address the underlying cause, and then only the glaucoma will resolve. So another patient, a recent patient of mine, a 24-year-old female who had an airbag injury to her right eye in a road traffic accident. She was referred to me because she was on multiple medications, bimetoprost, timolol, brinzolamide, brimonidine, and 2 tablets of Dimox, which she was tolerating maximum, and prednisolone acetate. Her best corrected visual acuity was 6/24. Intraocular pressure was 44 millimeters of mercury. And you can see here there is chromatic mydriasis, the lens is in place, not much of phacodonosis. On the angle, you can see that there is a significant angle recession. The fundus already showed a beginning of glaucomatous changes with an NFL defect. It's been 1 month post-surgery. So what are the possible mechanisms in this patient? Because it's 1 month and she's been on steroid, it could be steroid induced. Also, angle recession or a trabecular mechanism cannot be ruled out. So what do we do? First, we stop the predacetates, switch to fluoromethanol and reviewed the next day. IOP remained at 42. Many times, if it is a steroid response, you see a drop, even if it is 1 day, but we saw none. So this is a patient with 1 month post-trauma, possibly no steroid-induced component, disc damage already present. What do we do? Definitely, we need to operate. So one should not postpone surgery in such patients. We did a trap with mitomycin C. She's doing well. It's 2+ weeks now. BCVA has improved and her pressure is 12 millimeters of mercury. So management generally in these acute glaucomas following trauma is medical with maximal tolerated medications. We need to give the full dose of acetazolamide, also many times oral glycerol. Usually it resolves in 1 to 2 weeks, but if no response, confirm the mechanism and treat surgically. High femur is another problem which leads to glaucoma, and it is more common in the grade 3 and grade 4 high femurs. Initial management is conservative with rest, with head elevation, maximal medical management, and close follow-up. But in many situations, in 5% of these patients, you might need to resort to surgical intervention. So patients with more than 50 millimeters of mercury for more than 5 days, and all these criterion are there. But remember, these are for healthy eyes. If you have already eyes with comorbidities, you will have a lower index for intervening. So you can see in this surgical video, the clot is being removed, and I've combined this with a trabeculectomy because this patient also had angle closure glaucoma, and that was complicating her intraocular pressure. So a gentle washout along with or without a trabeculectomy will be required, but this is only in a small minority of cases. Angle recession results in 100% of eyes with high femur, and 9% of these eyes develop glaucoma. So the time of onset can be early to several years post-injury, and any patient who has more than 180 degree of recession, follow up for glaucoma by a lifelong annual exam. In any patient with raised IOP with angle recession, initial medical management is indicated. If there is non-control of IOP and progression of disc and field changes, we need to resort to trap with mitomycin C, but this carries a slightly higher risk of failure compared to primary glaucoma.
My apologies, Dr. Murthy. Yes.
Yeah. Done. Direct management towards the operating mechanism for IOP raise. Do not hesitate to intervene surgically. Liaise with other specialties. Discuss prognosis and risks with the patient adequately. Thank you very much, Dr. Parul. Thank you.
Thank you, Dr. Murthy, for such a concise talk. And with this, we move on to our last talk without much ado. And I invite Dr. Öztürk, who is a faculty, glaucoma faculty at the Başkent University, Istanbul. She is an associate advisory board member at the WGA and has keen interest in biomedics and management of complicated glaucomas. Over to you, Dr. Öztürk, and I request you to please stick to time. We are already delayed in this session. And my apologies to Dr. Coker for delaying the session. So over to you.
Okay, thank you very much. Thank you very much for this invitation to the meeting, and I will try to be as fast as I can in this very challenging secondary glaucomas due to uveitis. And high intraocular pressure during the course of uveitic inflammation is a common and frequently serious complication. And if the high IOP is of a temporary nature and does not cause permanent damage to the optic nerve, we call this uveitis-related ocular hypertension. And if this IOP increase causes glaucomatous optic neuropathy, we diagnose these patients as uveitic glaucoma. And when all uveitis cases are evaluated together, the prevalence of glaucoma or ocular hypertension was reported between 5 to 20% in all age groups. The intraocular pressure in an inflamed eye can be low, normal, or high in different circumstances because this is a multifactorial process that involves cellular, biochemical, and morphological changes. Aqueous production may decrease due to ciliary shutdown, and aqueous outflow may increase, both resulting in low IOP. On the other side, the increased density of the aqueous and the inflammation in the outflow pathways may lead to high IOP. Additional morphological factors such as pupillary block, synechia formation, and detachment of the ciliary body may also play a role in the IOP changes. Steroid treatment as well may again increase IOP accordingly, and in the chronic period, progressive changes may occur in the ciliary body as well. And depending on which of these factors is more prominent, a wide spectrum of paradoxical problems may arise. Gonioscopy is a fundamental tool in all uveitic patients referred to us, as there are a number of mechanisms involving the angle. It gives us a better understanding of the etiological factors, enables disease management, and provides prognostic outcomes. For clinical purposes, it is useful to consider the timing of the rise in IOP relative to the onset of inflammation. Based on these factors, uveitic ocular hypertension or glaucoma can be classified as inflammatory ocular hypertension syndromes, uveitic angle closure, steroid-induced, or chronic mixed mechanism ocular hypertension or glaucoma. Glaucoma is more commonly associated with anterior uveitis and with chronic forms of the disease, such as Fuchs, Posner-Schlossman, herpetic disease, JIA-associated uveitis, and Behçet disease. Increasing age and longer duration of uveitis are also identified risk factors for IOP elevation. In glaucoma diagnosis, OCT is a very common clinical practice, but OCT has the potential to confuse us in uveitic glaucoma patients because peripapillary measurements may be affected by macular edema and surrounding tissue leakages, which may cause a falsely thicker RNFL. This finding may lead to misinterpretation of the results as having no degeneration in the optic nerve, but when checked with visual fields and even with OCT angiography in recent studies, we can see suggestive findings of glaucoma. You can also see the opposite as well. After medical therapy, when optic disc edema resolves, the underlying optic nerve cupping becomes visible, as does relatively thin retinal nerve fiber layer. And this may be misinterpreted as glaucoma progression if OCT parameters are not assessed in the context of other clinical findings. So to avoid misdiagnosis, screening for glaucomatous RNFL changes in uveitis are recommended during the quiescent periods. Anterior segment OCT or UBM are excellent tools in evaluating the angle. UBM allows us to see the angle even in the presence of blurred cornea, and it is the only method that shows the ciliary body, which is useful for diagnosing especially chronic ocular hypotony. It also helps to evaluate angle closure secondary to anterior rotation of the ciliary body. One of the challenging problems regarding IOP rise in an uveitic patient is whether it's due to steroids or uveitis. Steroid-induced IOP elevation does not occur suddenly, rather it develops gradually over the first few weeks, and IOP usually returns to normal within 1 to 4 weeks of discontinuing the steroids. The key point here is that steroid treatment improves ciliary body function, which increases aqueous production, but this should not be considered a true steroid response.
I'm so sorry for intervening, Dr. Surkar. Can we please conclude in a minute?
Okay,
We've delayed. Yes.
Okay,
I'm so sorry.
Coral, if you want, I can go directly to the key points. I was planning to talk about some surgeries and so on, but
I'm so very sorry. Yes.
I think it is better to give the key points here.
I would really appreciate
as a summary.
Yes.
Well, I want to give some key points. Our patients with uveitic glaucoma are distinct from those other. Our main principle is to treat inflammation, followed by IOP control. And it would be appropriate to seek assistance from uveitis and internists. And it is critical to maintain strict management of inflammation during the perioperative period. Thank you very much.
Thank you so very much for accommodating my request, and my heartfelt apologies for intervening in between. And I'm so sorry for the delay in the session. Thank you so much. Thanks to all the speakers.
Thank you very much, Dr. Barar. Sorry for that, but inshallah next time we will be a little bit more stress or strict on time. I think Dr. Zainab, she was the last and she didn't get the chance, but maybe inshallah other session. So if you can, thank you very much for all. Sorry. Thank you, Dr. Barar. Thanks a lot.
Thank you. Okay.
Okay.